Hello, and welcome to the latest National Lipid Association Lipid Insights podcast. I'm your host, Dr. Peter Jones. Today, we're covering the just-released 2026 ACC-AHA Multisociety Guideline on the Management of Dyslipidemia and its clinical implications for lipidologists. And I couldn't be more excited to dig into this with two leading experts in our field. First, I'd like to introduce Dr. Joseph Saseen, one of NLA's representatives on the ACC Writing Committee. Dr. Saseen is a past president of the NLA. He is a professor and associate dean at the Skaggs School of Pharmacy and Pharmaceutical Sciences at the University of Colorado Anschutz Medical Campus in Aurora, Colorado. Joe, great to have you.
Thanks for having me.
Next, I'd like to introduce Dr. Dinesh Kalra. Dr. Kalra is the president-elect of the NLA. He is a professor, chief of cardiology, and director of the Lipid Clinic and Advanced Cardiac Imaging at the University of Louisville in Louisville, Kentucky. He currently serves as the ACC governor for Kentucky and is the chair-elect of the ACC Board of Governors. Welcome, Dinesh.
Thanks for having me, Peter.
Oh, that's fantastic. Well, listen, these guidelines sort of jumped out at us, I have to be honest. I mean, they came out on the 13th of March, and we're a couple of days after that, and here we are. These guidelines were published on the 13th in both Circulation and in JACC, and it's a marvelous document, all 134 pages, so it's certainly not a quick and easy read. But I will say it has some fantastic graphics, and for those who want to go through it and learn what you need to know as a clinician, and you've got limited time, you can spend your time going through these fantastic graphics. They list all the class of recommendations for each area that it goes through in the guidelines. So I do encourage you to download the complete document from either Circulation or JACC. Now, I'll have to say that when I read the guidelines in 2018, as a lipidologist, I wasn't very thrilled with the fact that they removed LDL cholesterol as a measurement and a target of our therapy and sort of removed goals, and instead told us to assess risk and then to assign appropriate statin intensity based on that risk. And, there was nothing wrong with that. I don't think. It was just hard to talk to the patient about what we were treating and why we were treating and what was happening from all that intensity of statin by not necessarily having goals and targets. But what thrilled me is when I read the guidelines, LDL cholesterol is back. And so the first question I want to throw out there to you, Joe, is so we now have LDL cholesterol as a measurement and as a target, plus we now have goals. Why don't you fill us in on that?
Yeah, I think it's important to note, as you highlighted, there were some few missteps. And it really started in 2013 when all goals were pretty much systematically eliminated. Then 2018, thresholds came back for two treatment benefit groups were really sort of hard for clinicians to wrap their head around. So now we do have, for our major treatment benefit groups based on risk and subclassification, discrete LDL cholesterol goals. Now, regardless of what you hear on social media, we still hold the term thresholds mentioned, which if you really understand the language, you probably deduce that they mean goals, but now the language is LDL goals, less than 100, less than 70, or less than 55, depending on your patient population and their level of cardiovascular risk. Because that's a central theme to these guidelines. But it's not just LDL, because non-HDL is highlighted as a corollary target goal also to achieve, and also consideration for ApoB as a central measurement to help with treatment intensification. So I am also grateful that goals are back. I hope that we can get it recognized as a quality measure by our payers, which I think will also help move the needle, but very happy to see that. And I think that From a clinician standpoint, this is what clinicians have wanted, regardless of whether there's that 100% explicit data proving every single goal.
Yeah, I think that's fantastic. And I do think it's important because I see the guidelines as saying it's not just LDL cholesterol is what we're trying to reach on a threshold with treatment, but that non-HDL is now a co-primary target of our therapies. Is that correct?
Yeah, it is. And it's going to push the needle for more intense LDL lowering. So it's not a more intense treatment, I should say. So it's going to capture those atherogenic lipoproteins that may still be elevated, or the remnant risk that we have after you get your LDL just to goal. Hopefully the idea is that you get it all controlled and further reduce cardiovascular risk in your patient. But you're correct. That's my interpretation also. It's a co-goal. Think of it that way.
Yeah. And then of course the ApoB, it's not recommended to be done routinely, but when is ApoB supposed to be used by either clinicians or lipidologists in helping decide on the adequacy of therapy?
It's really in your populations where we know that there's discordance between ApoB and LDL cholesterol. So in our populations that have metabolic syndrome or diabetes, or high triglycerides, those are really the populations where we know if we just rely on LDL cholesterol, we're going to be misled to some extent. Even when you incorporate non-HDL into that picture, there's a very good argument that ApoB is more appropriate in those populations. I think you'll also find that some clinicians have preference to use ApoB in other populations too, but those are sort of the big ones where ApoB I think is worthwhile.
Dinesh, you have any comments?
Yeah, I have a few comments. First of all, as you said, I think the framing of the guidelines is no longer management of cholesterol. As you said, it's management of dyslipidemias. And so as Joe was pointing out, and you correctly said, it's Lp(a) as well as ApoB and the remnant particles. And I think the focus is now more on all the atherogenic lipoproteins rather than being confined only to LDL. The other thing I really liked is this notion of taking risk right from the start and moving the needle to begin early and think about lifetime risk. So there's several things I like about this guideline, but the return to goals reminded me, have you ever watched a soccer match in South America? The commentator just goes on, goal! And then I saw this, just like Joe. I mean, Joe is on the writing committee, so he knew that, and I knew this was coming, but it's just that sort of excitement. Okay, patients want to know if they've reached goal, just like they do when you're treating blood pressure. I think this will be an actionable document, so I'm excited about that.
Yeah, that's fantastic. And the other lipid that was mentioned in the guideline is Lp(a). So what do they have to say about that this time?
Yeah, Lp(a) finally getting on the proper bandwagon, in my opinion, to recommend in adults to check it at least once throughout the lifetime. And we know that it's genetically determined. And there's, it does call out that there's some variability in some populations, like during menopause transition, during pregnancy, that there may be, in that reason, that population may be reason to check it twice to see where a patient's at, if it actually changes significantly or not. But that's a clear alignment with some other statements by the National Lipid Association to recommend universal testing of all adults. And that may trigger cascade screening, or more importantly, to identify other populations that you may need to look for residual cardiovascular risk, despite not having therapeutic entities that purely, meaning medicines, that purely lower Lp(a) as approved products. I think we're on the brink of perhaps having them. I think it really highlights the importance of looking at Lp(a). It's a risk-enhancing factor. It's generically inherited, and we know it's very strongly associated with cardiovascular disease and aortic disease.
Yeah, that's true. One of the things I also noticed was that on attempting to lower LDL to reach these thresholds or goals, that besides statin being the core treatment, initiation of treatment, we have other drugs that have outcomes benefits from lowering LDL cholesterol, but the guidelines don't tell you that in any specific way how to add them to statins. Is that correct?
It is correct, because you have to follow sort of the data on how non-statins that lower LDL cholesterol have been proven. And most of the time, it's on top of statin therapy, except for bempedoic acid, which clearly is in the statin, quote, intolerant patient, which means either zero statin or a small dose of a statin. So the recommendation is try best as best possible to follow the evidence. I think there is a very clear message that it is statin first for patients with elevated LDL cholesterol. We're never going to get away from that. But we are sensitive to all the data that has gone beyond that, either in that statin intolerant population like bempedoic acid, or as an add-on like what we have with the PCSK9 monoclonal antibodies and also with ezetimibe. So we do see the call out there. Matter of fact, there's quite a bit of data with the PCSK9 monoclonal antibodies, data that aren't even represented in the guideline because of timing of where I'm speaking about the Vesalius data. But the order, I think, is always statin first if possible, and add on thereafter based on where the evidence lies, or if you have a patient who cannot tolerate statin therapy or cannot tolerate the optimal dose to get their therapeutic goal, which is their LDL goal, then to go towards the non-statins.
Dinesh, any thoughts?
Yeah, I completely agree. I think the wealth of data for statins and is the reason they chose it as foundational. In fact, there's a recent massive Lancet meta-analysis, again, reinforcing how safe statins are. And so I think they got that completely right. But as you both pointed out, since the last set of guidelines, there have been many new trials that have come out, Fourier, Odyssey outcomes, Clear outcomes, and they've even gone into other drug spaces for other conditions. So I think this was very masterfully done, and the sequence sort of encapsulates what clinicians do in practice. You choose ezetimibe first because it's easy, it's a pill, it's cheap, it's well tolerated, and then you move on to the somewhat little more expensive therapies. But they do frame patient preference and access and all of those clinically relevant issues in making those recommendations.
And Joe, I did know that the guideline committee added this threshold of less than 55 milligrams per deciliter in very high-risk individuals. So I think everybody was wondering whether they were going to actually put a lower goal in there, but certainly no inclusion of the ESC extreme patient population with a goal of less than 40 milligrams per deciliter. Is that correct?
That is correct. The lowest, despite what social media may say, the lowest recommended goal in this particular guideline is 55. Now, that's an evidence-based recommendation based on the ranking that correlates with each of those specific populations. There's now five LDL treatment benefit groups, not 4. It got expanded. And there's also another treatment group, which is with hypertriglyceridemia. But I think if on the individual basis, I think there are some clinicians that will choose to be more aggressive. It may be beyond the core guideline recommendations. Doesn't mean that there's not any evidence to support that. It just means that the interpretation of the best available evidence led the group to endorse less than 55. And I'll say in the 30s is less than 55, which is also less than 42. So it might be, and some of that is, you already mentioned shared decision making. I think that getting a common sort of core goal is important, but you may have a patient who chooses to treat more aggressively based on their individual circumstance, or conversely the opposite, or a clinician that really is aware of a patient with polyvascular disease, or maybe polyvascular disease with symptoms of ongoing angina, or whatever their circumstance is, or even a CAC score of above 1,000. That would be somebody where you want to go quite low too. I think it accommodates those other circumstances, but just remember, whenever a core recommendation is recommended in these guidelines, according to the evidence grading, you really have to be able to defend it and label it with a classification and level of evidence. And I think that's where some of maybe the contrary opinion that we've heard is, some people say these recommendations sometimes didn't go far enough, and some people say they went too far. You're going to get both sides of that, but I think there's always clinician judgment, which is something that needs to be respected, and most importantly, the patient's opinion too.
Absolutely. I absolutely agree with that. Dinesh, the other thing that I noticed in the guidelines that's quite different is the uh, risk assessment calculator. So we've done away with the pooled cohort equation, the PCE, and they now come up with using the Prevent ASCVD risk calculator. Can you tell us about that?
Yeah, that's another big foundational change, and I think it's high time that gets adopted because, as you both know, the pooled cohort equation in some studies was overestimating risk in about 30, 40, 50% of people. And so, before we apply evidence-based therapies to people and guide them for prevention, you want to be sure that the calibration of your tool is good. And if you remember the pooled cohort equation, when it was derived, there were about 25,000 people in the derivation data set, but it went all the way back to older studies and databases from the 70s and 80s. So what we needed is a more contemporary database. And this database had 3 million people in which it was derived and about 3 million people in which it was validated. And the biggest advantage is that the calibration is really good. What calibration means is that if you predict somebody's risk of a 10-year event is 10%, your calculator comes close to that, and that gets you a calibration value of about 1, which is good. The PCE had a calibration value of about 0.55, so sort of in the poor range. And so the ability to predict an event rate that matches what you really see is really important. And that's the reason, as you see, the treatment thresholds based on the Prevent ASCVD rates have been adjusted so we don't undertreat people. I think both of those in conjunction are going to mean that we're treating the right kind of people. And as I said earlier, we're shifting the conversation to treating people much later in life to now being able to treat them earlier before atherosclerosis starts developing, before the horse leaves the barn, so to speak.
Yeah, I mean, I think they recommend considering using the Prevent risk calculator by age 30, which means starting earlier with assessing patients. And I also think it's important that it includes other factors in there that relate to cardiometabolic kidney disease, because it includes diabetes or hemoglobin A1C, BMI, EGFR, things that weren't really included as part of the old PCE. So I think it's a great assessment of risk, particularly starting earlier in life and catching that person younger, and keeping up with our whole idea in lipids, where we start earlier, get them lower, and treat them longer. And using the Prevent might help us get to identifying people at a younger age where they might benefit from therapy. Now, they still use the same risk identifications based on the 10-year percent, right? It's still low, borderline, intermediate, and high risk. Is that correct for 10-year risk?
That's correct. And I should also point out, and thank you for bringing that up again, because it's an important point. It's not just 10-year, but also the 30-year risk.
30-year.
So, when people are young, you want to calculate both. But your point's well taken. The risk strata stay the same, but the numbers for those strata have been shifted left. So now, a low risk would be less than 3%, rather than in the past it was 5%. Borderline would be 3 to 5% 10-year risk of ASCVD, which means non-fatal plus fatal MI and stroke. And then you have an intermediate risk category, 5 to 10%, and a high risk category of more than 10%. So this way you're capturing more people and putting them in the right buckets accordingly. But you brought up a real important point. In a young person, what you don't want to miss is they may have a low short-term risk of 10 years, but if their 30-year risk approaches 10%, then the guidelines really spur you to do something more rather than just focus on the short-term risk.
And if I may add one thing that I love the Prevent calculator because of the enhancements and even the optional inputs that you can put in there that further refine risk. We've been introduced to this with hypertension. And I always remind people that when you do the Prevent calculator, you're going to get 6 scores, basically 3 sets of them. and there's a 10-year and 30-year risk projection. But for lipid management, our guidelines are directed towards the ASCVD risk. There is the CVD risk, which is something that incorporates heart failure, which is really, it's for hypertension management. So I just remind everybody that you need to make sure that you're looking at the ASCVD prediction and not the CVD or the total CVD score.
Do you know whether electronic health records have the prevent available for clinicians to use now, or is that going to take a while to get out there?
Well, I know we're working on it. We have Epic at our institution, and we are actively working on it, but we don't have it yet. I don't know, Dinesh, if your institution has it figured out yet.
It's not a dot phrase for me yet, but it's easy enough to get on the website on the calculator. It takes only 30 seconds to do it, so it's fairly easy.
Yeah. Hopefully, it won't take long to get into the EHR so that we can all have availability and can use it, and all members of the care team can have that available. Now, one of the other things that I think was interesting, Dinesh, was in as a risk enhancer, particularly in primary prevention, even though you tend to use the prevent and they may be intermediate risk. We've always talked about using the coronary artery calcium score in some selected patients. What do the guidelines say anything about the CAC score, when to use it and how to use it?
Yeah, I think CAC has been elevated, and that's a good thing, because I think using CAC selectively in your borderline risk patients or your intermediate risk patients really allows you to have a more informed discussion with the patient. So it can really serve as a tiebreaker and a tool to refine your risk assessment, because the visualization of subclinical atherosclerosis, helps you decide that this patient is more deserving of a statin. So that's number one. It can propel you to start therapy. By the same way, it can also de-risk a patient. So, if somebody has a calcium score of 0, then you say, well, I have some time. We can wait 3 years, 7 years, depending on the other risk factors, and we can withhold therapy after an informed discussion with the patient. There are some places where you don't want to withhold therapy, like FH or people with, horrendous diabetes, etc. But in most patients, that is applicable. And then two, I think the guidelines have really framed calcium as a way to tell people what kind and intensity of therapy to start. For example, Joe mentioned that if the calcium score is more than 1,000, we know the risk of those individuals is similar to the risk of people who previously had an MI. So these people, even though they are asymptomatic and we used to think of them as primary prevention, they're really falling in the secondary prevention bucket. And so the guidelines correctly talk about using intensive statin therapy and intensive goals in those people to get to less than 40. So as you mentioned earlier, they're very nice graphics. I would encourage people to look at the graphic for calcium scoring. It does a really nice job of informing patients and physicians where they want their LDL goals to be. And I should mention one more thing. It's not just a dedicated calcium score. You can use opportunistic CTs done for other reasons to look at calcium. I think that's a very important concept. So if you're a physician in the clinic, many of these people have had non-contrast CTs for lung cancer screening or a CT done for some other reason. If you have a visual assessment of severe calcium, that's a very helpful tool. You don't have to order a separate calcium score.
Yeah, I think it was a class recommendation 1 for, based on calcium score alone in primary prevention to, have an LDL goal. I mean, if you're less than 100 on calcium, you get LDL less than 100. If it's 100 to 300, it's less than 70. And if you're more than 300, it's got to be less than 55. And I think that's an important thing to remember in primary prevention, that more intensive treatment based on calcium score is something that we don't always think about. And I think that's an important part.
And you might even have the patient who has a small, in the single or double digit score for coronary artery calcium. It's not a class 1 recommendation, but there are 2A recommendation to consider therapy in that kind of patient. And the reason I like looking at that, it's not a class 1, but as we all know, coronary artery calcium only looks at hard plaque. So you might get a false negative. You have a true positive if you have calcium score that's up there, but some patients with soft plaque may be underestimated with the CAC scoring. So it opens the door that you may still treat some other patients that don't look as bad, and maybe that's part of the discussion that you have, and consider other factors ongoing with your patient.
Yeah. Now, we talked about measuring LP(a) at least once in life, and they consider a high level being a greater than 125 nanomoles per liter, which I think that's at least the top 20% of the population with a high LPA. We don't have any treatments for LPA yet, and we don't have outcomes trials. That's going to take a while, but were there any recommendations as to how to use a high LPA in treatment decisions? Joe?
It definitely comes up as a risk-enhancing factor in your patient population that is primary prevention, where you're looking for other risks to drive your decision or to confirm your decision. I don't want the impression to be that you should use a PCSK9 inhibitor to specifically lower LPA, but there's a call out that in your patient who has clinical ASCVD, if they're not at goal and they need a treatment, that if you choose an additional non-statin, that if you choose a PCSK9 inhibitor, that you may also get the benefit of lowering LP(a). I think we will know a whole bunch more very soon when the Horizon trial reads out, which is of specific LPA lowering therapy. But that's maybe a little hint to the future, or a suggestion that if it helps people get a prior authorization approved by their insurance, I'm certainly good with it. But I don't want it to be interpreted that this guideline's recommending a certain drug to lower LP(a). It sort of is a hybrid interpretation.
Right. Well, I tend to agree. I mean, at least there is some data that people with high LP(a), when a PCSK9 is added, they seem to be not only high risk, but they tend to get even more benefit from further LDL lowering by that mechanism. So it's a reasonable thing, but I know it's not part of the guideline. That's what I wanted to make sure that got through. One of the other lipids to talk about, and you mentioned it with metabolic disease, is high triglycerides. And what was Joe, recommendations for managing severe hypertriglyceridemia?
Yeah, everything with severe hypertriglyceridemia, there's some enhancements with some of the newer therapeutic agents that are available, specifically olezarsen. Plozasiran is available also, even though it wasn't in time for this particular guideline. But for the patients who have persistent chylomicronemia, specifically FCS, those agents are recommended. But these are patients with significant elevations, extreme elevations in serum triglycerides. I do want to highlight that when you have patients with any elevation in triglyceride, there is an important role to emphasize and educate patients about lifestyle modifications, to look for excessive alcohol, and do all the routine things that we normally would do. There is a more structured approach, though, in this guideline that aligns with expert consensus, where you have maybe other options for your patients with established ASCVD depending on their elevation in triglycerides. We're not talking about the extreme elevations. We're just talking about elevations typically between 150 and 499, where icosapent ethyl, because the REDUCE-IT data, which has been available for quite a long time, still does have an evidence-based role in that particular setting. So I think the biggest changes are really in our extreme elevations with the onslaught of the ApoC3 inhibition that we can get with olezarsen, which is clearly outlined in this particular guideline. But also, we do have another therapeutic entity, plozasiran, even though it's not in the guidelines, only because the drug recently was approved. Right.
Do you have to have a genetically determined FCS to get those drugs, or can you, if it's polygenic hyperchylomicronemia with pancreatitis, is that enough?
This is the ugly truth. It depends. I mean, because we're looking at agents that really need prior authorization, some companies will require that and some may not. I think that's something that unfortunately may not be the most evidence-based approach. Some argue that it is an evidence-based approach to require genetic testing, because in some of the studies where people had genetic testing and confirmation, that we have the strongest confidence that there's benefit. But that is something that varies depending on the payer system, in my experience. Dinesh,
What do you think? Dinesh, what do you think?
Yeah. I've had luck with using the North American FCS score. And so to Joe's point, I think it depends a little bit on the company, but if you have good documentation of recurrent episodes of pancreatitis, the patients, tried a diet. It helps really if they had a family history. So things that go into the NAFCS are really helpful. So if your score is about 45 or so, you have less trouble. But if you have somebody who has not, you haven't excluded secondary causes, and the patient hasn't tried to exclude secondary causes, like you haven't fixed their thyroid disease, diet, alcohol, etc., and that's why it's polygenic. There you might have a lot more difficulty, understandably. So, but that's good to know that these drugs are mentioned in the guideline. But I'll go back to Joe's point. I think the guideline does focus on triglycerides-rich lipoproteins as being mediators of atherosclerosis, doesn't leave that out, doesn't focus only on LDL, and there the approach is very sensible in that get the risk down overall, lower the LDL to as much as possible, and then it gives icosapent ethyl a 2B indication. Again, a little different from European guidelines where they have a 2A indication based on the reduced data, but I think that's still a good option.
Yeah. One of the things I wanted to mention about biomarkers was HSCRP. Is that even mentioned in the guideline, Joe?
Yeah, it still will remain because of data that is irrefutable. It still is absolutely a risk enhancing factor. So that is, it's still strong in there. And I think it's part of your shared decision making or clinician judgment when you're evaluating a patient to see if you're on the fence. A primary prevention patient, you're not certain to treat it, is another element that, if elevated, should influence your treatment course.
Do they make any recommendation about using colchicine?
This guideline didn't go to the colchicine route. I'm not endorsing it or not endorsing it, but and there's, I will say, beyond this guideline, there's some good data with colchicine, but there's also some neutral data showing that it doesn't have the impact maybe that we think. So it's one of those other things that once you've done everything possible, your hands you just can't reduce residual risk because of a contraindication or just not having the available therapeutic options. Maybe that's something you consider, but it's not in the scope of the dyslipidemia treatment guideline.
Okay. And, some special populations to talk about, well, not special, but important populations to talk about in just general clinical practice. There are recommendations to screen all kids, right, for lipids? What age?
Yes.
What age? 9, 10?
So it's between, so obviously adults 19 and over, but kids 2 to 4, I believe, if they have a strong family history. If not, personal history, strong family history of either premature cardiovascular disease or high cholesterol, you can screen as early as age 2, but otherwise 9 to 11, which is what the American College of Pediatrics also recommends.
Yeah. Okay. That sounds great. And then on the opposite end, is there any comment about older adults? Like, do you initiate treatment and primary prevention over the age of 75? When do you talk about deprescribing therapy, so forth?
Yeah, I think the statements do align with what the NLA's statement is. There's a statement in 2024, 2025, I can't remember exactly which year, AGS in collaboration with NLA, that basically do highlight you treat the patient, not their numeric age, but their physiologic age, incorporate shared decision making. As we all know, we've seen 82-year-olds that are quite young for their age, and we've seen 82-year-olds that are near the end of their life. So deprescribing is appropriate when patients are near the end of their life, or when they choose to deprescribe or express interest in that. There's always choice, and I'm talking about the primary prevention population. We don't have the strongest evidence from a randomized prospective controlled trial in the old population, which is above the age of 75. We will have some coming around the corner. We just don't have it yet. So we're always going to live in this world where it's shared decision making with some data. There's actually quite a bit of observational data that patients who are older, who have primary prevention status, that they benefit from statin therapy. There's even some harm in some patients when you do deprescribe, that there may be an increased risk of events. But that's in a stable population, and it doesn't include end of life. End of life is a very different situation. And I'll make one disclaimer that if somebody has clinical ASCVD, I don't really care what their age is. I'm going to treat them. And we do have the option of maybe starting a little bit more gingerly, but we still can start with high intensity statin therapy.
You agree with that, Dinesh?
I do. I think the guidelines have a very sensible approach to this. They also give some numbers. So, if the life expectancy is thought to be more than 2.5 years, then it makes sense because, benefits accrue over time. And then, of course, look at polypharmacy, frailty, as Joe said. What does the patient want? And I think those are really important considerations. There's also a mention of, selectively using calcium. Again, if the patient's had a CT for some other reason and you see zero calcium, then that's shared decision making. You could tell them, I don't see calcium at this age, which means you don't likely have plaque. So, it's okay to forego a statin for now. So I think very, very nuanced, but very sensible recommendations overall. And same thing for cancer. Cancer patients have an elevated risk of ASCVD, so you want to treat them unless you feel like the cancer will shorten their life expectancy over the next year or so.
Fantastic. We're getting close to the end of our time, and I just wanted to say what do the guidelines do for us as clinical lipid specialists? Or does it really change the way we think? Is it going to maybe convince some of our colleagues who are more primary care to refer patients to us? What do you think, Joe?
That's a hard one. If I had to look in my crystal ball, I think that this is a great attempt to push the needle for more intense treatment. And I think a lot of primary care providers can do this without referring to a lipidologist. If you do have a complex presentation, somebody with FH, if you have a patient who's pregnant, who needs therapy, if you have some odd presentation, not just refusal of one statin or intolerance to one statin, but true statin intolerance, which is more than one statin, there's in severe hypertriglyceridemia, that's definitely a role for a clinical lipid specialist. But hopefully this empowers primary care providers to treat with confidence. I think it is going to change practice a little bit because we have to think more than just LDL cholesterol. We have to look at non-HDL cholesterol. It's real simple to look at, and you just add 30 to whatever your goal is for LDL cholesterol. And ApoB is an option. You only really need to, you don't always have to look at it, but we talked about the special populations. And thank goodness when your LDL goal is 70, your ApoB should also be less than 70 if you have a patient where ApoB is helpful, and 55 will be the same. It's just that when you're targeting 100, you have to adjust ApoB to 90. So there's a lot of harmony between that. But bottom line, to answer your question, Peter, I hope this leads to more aggressive treatment in patients with cardiovascular risk. And there's a lot of them out there.
Dinesh, you agree?
I couldn't agree more. I think the guidelines do make a focus of team-based care. So as Joe pointed out, a lot of things the primary care doctor should be able to handle on their own. And in fact, the NLA simplified LDL flowchart is really useful, and it kind of aligns with the guideline in terms of the numbers. So that's a very useful document to sort of dummy it down. The second point I will make is that, I think that it calls out for lipid specialists as a unique resource. And I'm glad that aligns with the position of the NLA that, yes, we want the majority of patients being treated by their family doctors and primary care physicians. But if you have difficult patients with, say, elevated risk from TRLs, or you're unsure about which new ApoC therapy to prescribe, then the lipid specialist is a wonderful resource. And there's actually a beautiful table in the guideline about when to refer to a lipid specialist. And I think that'll help the NLA's desire to elevate lipid specialty to a taxonomy code, because they do provide a special service in complicated patients.
Absolutely. And we can't go without recognizing our registered dietitians as an important part of the care team. And, every practicing physician needs to know who their best registered dietitians are to help their patients on this journey, because it isn't just about medications and taking that. They still have to do their lifestyle, and they have to have access to exercise physiologists when necessary, and the whole bit. So it's definitely is an important care team that we have to involve. So any final comments, Joe, that you want the audience to hear about the guidelines?
I would say read the guidelines. There's going to be, I think a week after the guidelines released is an at-a-glance summary with a central figure to look at to give you a skinnier version. But I encourage, if you do treat patients, to read the full guideline if possible. And my biggest thing is just check LDL cholesterol more. I'm sort of always amazed that the highest risk patients sometimes don't even have their LDL checked once a year. And I think if we check more, we'll identify patients that need therapy, and it may push things. We would never not measure blood pressure. We should have maybe a similar attitude with LDL cholesterol.
Dinesh?
I'll just add to that for those of you in the trenches who are looking for simplified tools. The Guideline Central always distills down guidelines. There's also a simplified slide set available from the AHA. And I'll add to Joe's point, if you're checking LDL in adults, please check an Lp(a) also. I think the NLA has been advocating this for a long time, so has the ESC. It's a little late to the party from the ACC, but I'm glad they got there.
Fantastic. This has been a wonderful discussion, guys. Thank you so much. It's been wonderful to have both of you, Dinesh Kalra and Joseph Saseen. Thank you so much for contributing to this episode of the Lipid Insights podcast. Good night, everybody. Thank you for listening.